Hello and welcome to Tribe Talks. My name is Ken Deans, and today we're going to talk about strategies for breaking even financially when treating government-insured patients in a hospital setting. I'll start off by talking about the problem, and then we're going to get into solution sets and what to do going forward. So let's begin with the problem. CMS, the Center for Medicare and Medicaid Services, is a federal health insurance program for people 65 years of age or older, under 65 with certain disabilities, and any age with end-stage renal disease. So in the hospital setting of most health systems, as you can see here, we're reimbursed by CMS at typically less than 90 cents on the dollar of cost, and for nearly every government-insured patient treated. For some states, in fact, like those of us in Virginia, we're reimbursed at less than 80 cents on the dollar of cost. Collectively, we're one of the few industries where service will be provided to a consumer for less than the actual cost of producing that service. I know of very few retailers, for example, who would routinely and consistently, for every customer, every time, sell them a car or a television, a piece of clothing, or even a hamburger for 20% less than their cost of producing and delivering that item. This is precisely what we do in healthcare for government-insured patients, however. The healthcare industry is also one of the few types of businesses where an entity cannot legally turn away or refuse service to a consumer, specifically surrounding emergency care and treatment. The Emergency Medical Treatment and Active Labor Act, or as we call it EMTALA, is a statute which governs when and how a patient may be 1. Refused treatment, or 2. Transferred from a hospital to another when he or she is in an unstable medical condition. The avowed purpose of the statute is to prevent hospitals from rejecting patients, refusing to treat them, or transferring them to charity hospitals or county hospitals because they're unable to pay or are covered under the Medicare or Medicaid programs. According to Moody's, U.S. not-for-profit hospital medians reveal continued slowing revenue growth and weaker operating performance, declining to levels not seen since the recession. With government payers, primarily Medicare and Medicaid, now typically accounting for more than 50% of a hospital's total inpatient admissions each year, and the 65 or older population predicted to increase by nearly 2 million people per year for the next 15 years, providing service at a loss to an even larger patient population will very quickly become unsustainable. We must find a way to at least break even when treating government-insured patients. While most of healthcare is a consumer staple, much is also price inelastic. As a result, production improvement through emphasis on achieving optimal output and resource utilization will be the focus in attempting to highlight some examples of strategies that, if executed properly, could potentially bend the cost curve. In a hospital, the suite of products and services provided are really not that sensitive to price. Further, output is to a degree somewhat shielded to national income and unemployment, or at least certainly much more so than in other industries. Demand and supply analysis is the study of how buyers and sellers interact to determine transaction prices and quantities. Prices then simultaneously reflect both the value to the buyer for the next unit and the cost to the seller for that unit. So in trying to tackle any profitability challenge in a hospital, the most obvious places a manager must begin is by reviewing the cost structure, and in particular our labor use rates. Volume as a factor of revenue and production cost are at the heart of the challenge as we cost shift to commercial payers to compensate for running negative margins with governmental payers. So in order to attempt to even come close to breaking even in these areas, we really must examine the cost structure of producing a unit of service, which for us is one of the many multidisciplinary and multifaceted medical treatments and associated services that we provide. So operational efficiency and discipline become absolute imperatives. A tactic in this area would be to examine and analyze aspects of our cost structure in an effort to determine acceptable ways to reduce it. An organization might go about this in many different ways, including Lean Six Sigma analysis, benchmarking and performance analytics review, and utilization discipline. Irrespective of method, though, what we know at my organization is that labor, supplies, and purchase services constitute between 80 and 90% of our total operating expense. So therefore, surrounding cost it would seem most logical to begin focus there, placing an emphasis initially, for example, on many of the following elements of production. A key area is really to simply first compare yourself to others doing better than you are already. Take advantage of national benchmark data and review opportunities in the following areas. Consider using a standard target threshold for managing your organization, such as aiming for the top 50th percentile of performance in clinical areas and perhaps a top 33rd percentile for non-clinical areas, again, as compared against industry peer groups. Some examples include look at top productivity and FTE opportunities by department, top productivity performers, those that are above 105% of your targets, worked paid target FTEs or full-time equivalents, and patient days versus adjusted occupied bed. Take a look at nursing care hours per patient day. Overall, and then drill specifically into key service areas such as medical surgical, critical care, and followed by your ancillary and ambulatory departments. Take a look at turnaround and wait times, operating rooms, emergency departments, nurse unit beds, patient transport requests, and so forth. And then finally, really take a look at overtime utilization. Note that there's a threshold up to which it is more effective to utilize overtime as an alternative to additional employment. But similarly, there's also a threshold where it becomes counterproductive. So analyze this and determine the ideal threshold for your organization, which frequently is going to just be based off of your wage rates and your fringe benefit costs. Next, beyond labor and productivity, place heavy focus on supply chain and inventory expenses and process efficiency. Take advantage of group purchasing organizations available specifically to healthcare. Major GPOs to consider include Vizient, Premier, and Health Trust. Combined, these top entities had a shared annual spend volume of nearly $200 billion just in 2016. There are tremendous savings to be realized with manufacturers through group purchasing. Establish multidisciplinary variance analysis teams to minimize the use of multiple types of supplies and implants. Standardization is critical to cost containment. And manage stock on hand and minimum stockage levels in a given period aggressively. And minimize inventory where plausible. Consider utilizing just-in-time inventory models as well as suppliers that stock in your organization on your behalf, but only invoice as the inventory is utilized. Our mission, even as a nonprofit, does not include being all things to all people. So as such, we must narrow our focus to those things that do fall within our scope. In doing so, where there are elements of production that are not a core competency for us, especially in an era of increased demand for efficiency, we must consider selective outsourcing and seek benefits from economies of scale where we can. One caution here, however, is that outsourcing must be performed only where the total cost structure is kept in mind. Never move to outsourcing in a silo, because all engagements have some form of downstream or upstream impact, especially in a heavily interconnected micro-ecosystem such as ours. For example, a portion of our reimbursement is related to quality and patient outcomes. So purchased services left unmanaged, in the long run, could be equally detrimental if baseline measurements and outcome metrics are not being achieved. Frequently, being successful demands collaboration between business units. Hence, outsourcing in a silo is rarely a good idea. However, done as a part of a larger strategic and operational plan, it can offer great positive impact to the cost structure of production. Disciplines for review and consideration are shown here, but they include radiology, anesthesia, dietary services, and so forth. With the prevalence of quality digitization services across the globe, telehealth opportunities such as tele-ICU, radiology, stroke, home health, as well as primary care, televisits for non-emergency situations, all have viability and should be considered. Both specific to managed purchase services, as well as more broadly, always also evaluate the viability of joint ventures and mergers and acquisitions with trusted partners related to these services. There are many reasons to consider this, which range from strategic or elements of competition, or for risk aversion purposes, to simply for startup capital and operating expense sharing and support. No matter the reason, always at least consider and weigh the viability of strategic integration, such as mergers and acquisitions, when assessing ways to reduce the cost structure. Organizations should also focus on the clinical, operational, and financial deficiencies that drive high variation in care and add unnecessary cost. As we concentrate on cost reduction opportunities within the production process, given the seemingly one-sided and heavily weighted production input of labor, we must also focus on changing the overall hospital care delivery system too, which includes improving quality of care by reducing care variability. One such strategy of reducing production costs through high-level care delivery redesign and quality improvement is focusing on known high-cost conditions. A specific example of this might include the focus on a condition known as septicemia and the potentially ensuing septic shock that could follow. Sepsis, as it's more commonly referred to, is the single most expensive condition to treat in a hospital. Sepsis is a potentially life-threatening complication of an infection. If sepsis progresses to septic shock, blood pressure drops dramatically, which may lead to death. To reduce sepsis mortality rates, which are between 20 and 50%, many hospitals have established evidence-based bundles comprised of antibiotic administration, lactate level monitoring, and other elements of care. Mission Health, for example, the sixth largest health system in North Carolina, has streamlined surveillance by 75% while experiencing a 2.6% reduction in sepsis mortality rates and an 18% reduction in length of hospital stay. Since payment is predetermined whether a patient is hospitalized for 3 days or 6 days, the revenue generated is exactly the same. So simply put, a length of stay greater than expected drives up the cost of inputs such as labor, supplies, and purchased services, and creates a decreased per unit of service productivity. Whereas an equal to or lower than expected length of stay has the absolute opposite impact. With sepsis, for example, by initiating comprehensive and wide-ranging process improvement efforts, while avoiding the traditionally narrow subspecialty focused reviews, focusing well beyond the disease itself and on the entire care delivery system surrounding a specific diagnosis, Mission Health improved patient outcomes substantially. So by advancing cost-saving innovations, such as replacing manual processes with automation, establishing door-to-exit treatment protocols and treatment bundles, irrespective of whether sepsis was the primary diagnosis or not, and deploying advanced analytics for sepsis surveillance and patient tracking, they proved that it's not only plausible, but in fact possible to improve quality and reduce costs simultaneously. A dedicated focus to quality and patient safety can not only dramatically improve outcomes, but also can dramatically reduce costs due to a substantial reduction in days of stay, and therefore the cost of care. Sepsis is but one example for illustration purposes. There are dozens of similar care delivery redesign opportunities that, if aggressively targeted, would make an immense impact on production cost. Beyond sepsis, a proper strategy would most certainly include heavy redesign focus on improving the Agency for Healthcare Research and Quality's top patient safety concerns and indicators. Truven recently reported on 13 of the top 20 AHRQ patient safety indicators, highlighting the per-discharge impact on length of stay and total hospital cost, as shown here. With close examination of the length of stay and the total hospital impact, it's noticeable that the production cost across hospitals nationwide is filled with inefficiency and is ripe for improvement. Most certainly, by focusing heavily on areas such as these, bending the cost curve is very much possible. The mechanism to improve these inputs of labor, material, and supply chain, quality, and so forth could come in many capacities, including capital, as well as robotics, biomedical, modalities, and so forth, all to be heavily explored service line by service line. A wicked problem, by definition, has no complete resolve. Rather, tackling it is a methodical process of picking and choosing not just one, but a series of least otherwise detrimental fractional remedies to support navigating the broader problem. Trying to break even financially when treating government-insured patients in a hospital setting is a wicked problem. However, I believe attacking the cost structure of production in the way shown today, while considering economies of scale opportunities in doing so, will establish a strong first step towards doing this. I'll leave you with one of my favorite quotes from Albert Einstein. We cannot solve the problems we have created with the same thinking we used in creating them. So thank you, and go Tribe.